Good morning, everyone. I think I'm live already. The countdown already stopped in 5 minutes. It was way too fast. But anyway, so I was kind of preparing my stuff here. But yeah, good morning to everyone. Let me see who's watching. We are actually live on Facebook page of Amen Healthcare International and as well as IPAS Processing, the main page of IPAS Processing. Okay. So yeah, I guess it's been like 2 months since I haven't been doing some live lectures here in AMN Healthcare International for our nurses, especially talking about the NGN. For sure, today we are going to discuss about NGN, next generation NCLEX. All right, so the new generation NCLEX. All right, so before we start, I wanted to look at your comments and see where you're coming from. So if you are from the Philippines, kindly put it in your comments where you're situated. Okay, so where's your locality? All right, so if you're from the Philippines, put there what's your city in the Philippines. If you're from Africa, which country in Africa, or let's say what's your city, what's your locality, and if you're from Middle East or from Saudi Arabia, I love the people in Saudi Arabia. I worked there before, and I love to see nurses also watching us from there in the Middle East. Okay, and if you're from also from US, and then you can also comment there. Okay, so where are you joining from today? Let us know. From Yeah, that's from Amen. Thank you, mom, for facilitating this. So it's always like a pleasure on my end in behalf of IPAS Online Review and Mentoring Academy to do some important stuff, related to your NCLEX. All right. Hello from Tanzania, Mr. Reen. Is it Mr. or Miss? I'm sorry. Miss, I guess it's Miss Reen. I'm just watching. I'm looking at your profile picture. All right. It's springtime here in the US, so I'm kind of like having some rhinitis. I'm having some sniffles. Hold on. Hello from Cape Town, Tembali. Gladys from the Philippines, Miss Irene. Oh, okay, Miss Irene. So your full name, not full name, but your name is Irene. Yani from Japan. So we're everywhere actually, from Asia as well. These are the people who are striving to like do their NCLEX and be able to be successful on it. And I guess most of you guys are aiming to come here in the US. By the way, your NCLEX is also applicable to Canada and Australia. So we're also offering those, NCLEX review for, I mean, it's the same thing, right? Whether your destination is Australia or Canada or primarily US, it's the same context in your NCLEX, okay? We're doing the same program. All right, so we have a lot of aspiring nurses that wants to go to Canada and Australia as well. Even other nurses that are currently or presently in Canada or Australia. All right. So hello from the Philippines. That's Miss Rosemary. Uh, Pamela. Yes, Pamela Leona from Oman. From Zambia is happy to see you here commenting. All right. So yes, I guess we have some like 75 viewers as of the moment. So if you have time, kindly share it to your Facebook page as well or whatever social media platform that you have. Okay. So yeah, so hi to our students also in IPAS Online Review and Mentoring Academy, including the staff, including the educators, including the coaches. We have a lot of people, helping our nurses in our academy, in our community. It's actually a community. Okay, so yeah, I guess we can. Yep. Let's kickstart our formally kickstart our discussion today. Hi again to our viewers. Hope you all doing well with this Easter season especially. I'm happy to be here. It's been a while. Time is fast. That means to say that it's time to take your NCLEX too. All right. So did you know that procrastination is the master of all thieves? All right. It will only make easy things hard and hard things harder or even hardest. Okay. Of course, like I said, together with your AMN International, we have the same passion to help you on that journey, utilizing this beautiful platform to bring the best information possible to pass your NGN NCLEX. Okay, so I've been talking for minutes now, but my name is Jay. All right, so I'm a co-founder and lead educator of Bypass Online Review and Mentoring Academy. I'm situated here in Texas, USA, particularly in Beaumont, somewhere southeast Texas, and practicing as a nurse, living my life with God's grace and fighting life, as they call it. We are here for an hour discussion answering a case study geared towards developing your critical thinking skills. Okay, I'm gonna discuss about some critical thinking skills. All right. Well, that's basically your NGN, and ultimately your clinical reasoning or judgment. All right. It's all about clinical judgment. We will answer a test drill in a form of bow tie type of question. All right, based on a case study. It will be for sure a very very common topic in the exam and also in the clinical setting here in the US. So NCLEX nowadays is clinically driven. All right, so clinical reasoning, critical thinking, clinical judgment is way important in taking care of your patient. So without further ado, let's get it on, nurses. Okay. So by the way, please don't forget to share, like I said, in your social media, Facebook page, Instagram, TikTok, YouTube, whatever. And we are actually live also, like I said, through AMN and iPass processing FB channels. So yeah, so if you have YouTube as well, you can also share it. I guess we also have some YouTube on our iPass processing. Let's start. Okay, so let me share my screen. I haven't shared my screen yet, but yeah. So let's see what I can do on this. Hold on. From my computer. I guess I don't need to upload it. Hold on for a second, okay? I think I'm the one who is not ready. Slides. Forgive me about it, but let's see. Guess I have it here. There you go. So I don't know if it's showing on your end. Okay, while looking at if it's already shared, so let me look at your comments. Hi, sir, from the Philippines, ML Cruz, also Miss Agatha. So can you see my screen? Is it showing up on your end? Is it? I think I already shared it, but I don't know, for some reason it's not showing. Maybe it's kind of delayed. Oh, wait, there you go. Okay, so let me just it's probably delayed. Okay, so yeah, so this is in coordination or in collaboration with Amen and iPass. All right, so in behalf of iPass, I'm Jay again. So to discuss some good things about NCLEX. All right, so this is a bow tie question. All right, so let me discuss first what is NGN, the next generation NCLEX. I told you already that NCLEX these days, uh, which started April 1 last year, 2023, they changed the manner of asking you questions because they are already clinically driven. All right. So the manner of questions are based on the 6 functions of clinical judgment. Okay. So they established a certain model, which is the basis of their measurement, especially, of course, for you candidates, the entry level nurses that wants to come here in the US, clinically driven. And that is ultimately to better assess or evaluate you guys to validate how far are you in using your clinical judgment. This is ultimately to prevent errors from happening, to promote safety not only for yourself but ultimately for your patients, the most effective and the most sound clinical judgment, while doing some stuff or nursing interventions to your patients. Okay, so this is the 6 functions of clinical judgment. Okay, so this is yeah, so from recognizing cues, analyzing cues, prioritizing hypotheses, generating solutions, taking actions, and evaluation of outcomes. This is a measurement of your critical thinking skills before you arrive on a very sound clinical judgment. Okay, before you deliver care to your patient. Are you with me, guys? Hi, Sir Jay. Nice to see you on live. Thank you for all the lectures and support. Yes, sir. Thank you, IPAS family. Yes, yes, sir. I'm very pleased to be one of your lecturers. And yeah, thank you. I appreciate it. Okay, you passed the NCLEX already at first take. Very good, very good. Thank you, Lord. So, hello, I don't know how you say your name, but I'm sorry about that. But yeah, Connie as well. So, welcome, welcome. So, this is again your clinical judgment model, which was established by NCSBN. The NCSBN is the National Council for Board of Nursing, for the State Board of Nursing here in the US. They basically implement the exam. All right, they are in charge with the exam. All right, so they made something like a model again for them to assess you better in your clinical judgment. Okay, they're gonna assess you on your critical thinking skills, on how you recognize cues, what matters most. That's the hint there. That's the strategy there. So on how you analyze cues, critical thinking in relation to how you analyze cues. So in your end, so what does it mean when I have these cues, for example? And how you critically analyze, or let's say prioritize hypothesis. Where do you start? It's prioritization. All right, everything might be correct. All right, everything might be correct, but you have to choose the most priority for your patients. Okay, and you can have many conditions at a single patient on a single time, but it doesn't mean that all of them are priorities. There are some priorities, there are some high priorities, there are some intermediate priorities, and there are lesser priorities or low priorities. Okay, so you have to, of course, pick the most priority. All right. So moving on, we have generating solutions. So what are you gonna do then? All right. So they're gonna assess you on your critical thinking skills, on what can you do with that, with that hypothesis. Okay, and you have to take action. So what will I do then? All right, and lastly, evaluate outcomes. So did my interventions help? Okay, did my nursing care help? So you need to evaluate. They're gonna assess you on that as well. So the question is related to evaluation of outcomes. Okay, so this is just basically nursing process. They just broke it down into a simpler and a more specific way, especially in testing you guys in your critical thinking skills. Like again, I said, from recognizing cues down to your evaluation of outcomes. Are you still with me? Okay, we're still not in our case study. I'm just like overviewing what's going on with your NCLEX NGN, your next generation NCLEX. Like I said, this is what we usually do. This is the nursing process. This is the nursing routine that we're doing at the bedsides of your patient, practicing as a nurse here in the US. Okay? So they apply this one in a form of case studies. Okay, in a form of case studies. We have three types of case studies, by the way. All right. One is bow tie case study, because literally it looks like a bow tie, wherein you have to pick what's the potential diagnosis. We have to like drag and drop. This is what our example today that we're gonna answer. You're gonna drag and drop into the box. All right. What's your potential diagnosis? The potential diagnosis, the actions to take, the most important actions to take, because they may be correct, all of them, the choices. You have to drag and drop them, to a certain box. Okay, to certain boxes. Usually it's two, and the other one would be like the parameters to be monitored. All right, so it's usually like two out of all the choices, the most important parameters to monitor, and it should be consistent with your with your potential diagnosis. One is the other one, apart from Bowtie, there's also what we call as your standalone case study. A standalone case study, it's still based on case study. That's what we're talking about, by the way. All right, so everything is like according to case study. Okay. Another one is your standalone case study. Standalone case study is there's a case study, and there would only be one question related to that case study. But everything is based on this clinical judgment model, which is established by the NCSBN. The other one, the other one is definitely you will have this, kind of case study. They call it as your unfolding case study. All right, unfolding case study. It's based on a case scenario, and you have to answer 6 questions related to that case study, specifically assessing your recognizing cues down to your evaluation of outcomes. So it's more specific. And one sitting, All right. So in one sitting from a candidate, you're gonna have a minimum of three unfolding case studies. It's called unfolding because the story unfolds, 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 unfolds until you get the right diagnosis, until you get, the core of the problem. Okay. So yeah, so you're gonna get a minimum of three case studies. Okay, minimum of three case studies up to the maximum of five case studies. And the thing is, they're only gonna grade you three unfolding case studies. If you're going to get five case studies and you will never know, that's the trick there. I mean, that's the hint there. You will never know out of that five case studies what are the three case studies that they're gonna grade. So in other words, you have to do well in all those unfolding case studies. Okay. Number one is your unfolding. So it's just a summary, just to go an overview. Unfolding case studies. They have how many questions? Six successive or subsequent questions related to that case study. All right. And number two, one example is your bow tie. Okay, because it really looks like a bow tie. All right. And number three is the third type of your case study is your standalone. All right. The standalone case study is again from a case study. They're only gonna ask you one question related to that case study. Okay, so these are the three types of case studies. Case studies are just fraction of your NCLEX test. Okay, you're still gonna get multiple choice, SATA, and everything, the traditional ones. And I told you guys, okay, before I start our case study now. I mean, in a bit. I told you, please stop procrastinating, huh? If you are, if you are, this is a truth. This is a truth that we're in. Okay, I've been thinking about taking NCLEX, but I'm still like, contemplating. If you're contemplating, all right, if you are already capable of doing so financially and everything, I guess please take it. All right, because the figures are high. All right, the percentage is very high, not only in our course, on our program. Okay, we're gonna help you on that. But certainly, we have good figures, very good figures. In the NCSBN figures that they reported, it's up to 15 to 20%. I'm talking about international nurses who took the exam. All right, international nurses. Let's say from 38%, it went up to like plus 20. Let's just say plus 20. It went up to like 58%. So that's a big jump, from 38% to 58%. All right. So I want you to belong on that category, passing your exam. And please, if you're a retaker, please don't be discouraged. Okay, don't be discouraged because again, if you stop, and then certainly your dreams will also stop. All right. So if you dream to come here in the US, please, uh, you know, uh, please don't stop from dreaming. Okay, please don't stop from. I know it's gonna be a struggle, but well, struggles are temporary. Okay, struggles are temporary, and success is permanent. Okay, success is permanent in a sense because you can argue with it. No, no, sir, success is not permanent. Actually, no, success is permanent because you know what? It's a God-given success. So it's gonna be permanent. All right. And like I said, just sacrifice 3 months, 4 months, 5 months, or 6 months. Ideally, it has to be like 6 months. All right. Sacrifice or a little struggle. Okay. It's an adversity because you're working at the same time. You're a single mom, for example. You are parenting on a toddler, for example, or you still have a baby. And this is adult learning. This is an adult life. All right. So these are just sacrifices. These are temporary. And again, success is permanent because it's a God-given success. Your license. All right, your USRN license. Okay, so without further ado, so yeah, this is your clinical judgment. This is just another explanation on what is really clinical judgment measurement model? Again, I told you already, it's established by NCSBN. All right, so it's just simply the nursing process that we usually do routinely. Okay, so there's also this Christine Tanner. He actually established a model way back, probably like 30 years ago. She collaborated with Patricia Benner. If you know Patricia Benner, from novice to expert kind of model or theory in nursing. So she is, Christine Tanner is an advocate of clinical judgment. Okay, so clinical judgment. So in her model, she categorized it into four. That's basically nursing process, right? So on how you, for example, how you notice, how you interpret, how you respond, and how you reflect. What I'm saying here is that Christine Tanner is an advocate of clinical judgment. Now it's beginning to materialize, in other words, okay? So her thoughts about her model about clinical judgment is now doing so well in terms of how the NCSBN is evaluating the candidates. All right, 65% of the errors from an associated with the entry level nurses or from an entry level nurses are related to the usage of clinical judgment. Again, 65% of the errors coming from the entry level nurses here in the US are associated with clinical judgment. That's way too high. All right, that's way too high. This is according to American Journal of Nursing. Okay, so we want to limit that errors. Again, at the end of the day, who's gonna receive or who's the receiving oh. Okay, can you hear me guys? Okay, let's resume. I lost some audience. I'm sorry about that. So, yep, technical glitches. It's inevitable. You know that. Okay. So yeah, so let's start and answer a certain case study. It's gonna be a bow tie. So am I here? Am I here, guys? You can see me, huh? And I want to see it from your shout out or not shout out, but your from the comment section. We can hear you, of course. Okay, good. iPass processing. Hello, iPass processing. Okay, it's been a while. No, no, no. All right. So maybe I meant okay. Yeah, it's already fixed, I guess. So yes, sir. Okay. So resume. Okay. All right. So yes. So I think you can see it already. So let's answer this. All right. This is a bow tie type of question. Please, guys, when you look at your screen, whenever you take your NCLEX, all right, please, when you encounter case study, the first thing that you need to keep in your mind is that please don't take a look at it, the question, the right side of your screen, the right side corner. I mean, the right side corner of your screen. All right. So you have to take a look at first what's the case scenario is all about. Don't get too excited. Well, time is not your enemy in your NCLEX. Please don't get too excited answering your questions without looking at your case study, your case scenario, at the left hand side corner of your screen. Okay. So this is your case study right here. This is the scenario. So the patient complains of what? My foot is hot and draining stinky fluid. Okay? So my foot is hot and draining stinky fluid. What does it tell you guys? What does it tell you? Okay, I may need to look at other parameters. Okay, this is not enough in answering my question. All right. So yeah, so I may click the nurse's notes, history of physical profile, vital signs, and physician's order in order for me to get more, to recognize more. Remember, they are assessing your how critical thinking in terms of using your on how you recognize cues. All right. Click this one, either either whatever is you think is beneficial. Well, everything is beneficial here. Okay, so when you click the nurse's notes, when you click the nurse's notes at 1600, let's read it all together. Patient John is a 65-year-old male who presents to the hospital with inflamed wound to the right plantar surface of the foot, as evidenced by edema, okay, erythema, and mild odorous drainage. What does it tell you guys? What is this? Before answering our question at this early, clicking at your nurse's notes, what are you thinking? You're thinking about what without looking at your questions first, without looking at your bow tie type of question. Come on, come on. So what is this? I may need to get more parameters, get more information from this patient, history and physical profile, for instance. Okay, so I wanted to see an answer from you guys. I wanted to see an answer. I understand if you're not ready to take the NCLEX yet, you may be thinking, okay, I think I can, I may be losing my pace. I haven't started my review yet, so so I guess I really need to put myself into a position wherein I'm really ready in this exam. Infection, all right, infection. So let's take a look. Patient was admitted in ER 5 days ago and given clindamycin 300 milligram every 8 hours for 5 days. Okay. Patient reports adherence with the treatment, including his routine medications. Guys, the patient is already having or had 5 days of clindamycin. Clindamycin is good for anaerobic microorganisms, especially for skin outside of your, for example, outside of your GI system and outside of your gynecological system infections. All right. So anything, just try to look at this one. All right. So try to look at this one. Anything that is outside your tummy, GI infection, anything that is outside of your gynecological infection, as long as it's anaerobic microorganism, clindamycin is a good coverage. May it be, in your face, may it be in your hands, skin infections, whatever is outside your GI and your gynecological. That's an antibiotic kind of knowledge, all right? So it's good for anaerobic kind of microorganisms, all right? And what about the GI and gynecological? For example, like Clostridium difficile. Clostridium difficile is an anaerobic kind of microorganism. What's your drug of choice? Vancomycin and as well as metronidazole. So metronidazole is good for anaerobic microorganism pertaining to infections related to your GI at the same time gynecological. All right. So if you can, if you are practicing right now, that's why no wonder the doctors are prescribing metronidazole for GI infections or gynecological infections because they are good. They have good coverage in these particular infections, anaerobic microorganisms particularly. Okay. So yeah, just like your Clostridium difficile. Anyway, so it looks like it's already 5 days. Patient had clindamycin and it's not improving, right? It's not improving. It's already 5 days. By principle of antibiotic prescription, all right, the patient should be improving at a period of 48 to 72 hours. Okay, so that's about 2 to 3 days. All right, so the patient will improve. In general, if you're giving antibiotics, whatever kind of antibiotics is that, that's one of our principles that you need to remember as well. If ever the patient had already passed, 48 to 72 hours and it's not improving, which is obvious in this patient, well, you think about, this antibiotics is not working. All right. So obviously the clindamycin is not working. All right. So even though the patient is telling you that, he is adhering to the treatment regimen, probably the antibiotics and the routine medications that he's been taking. All right. The patient verbalized. Let's take a look at more, parameters. Patient verbalized that he does home remedies by soaking his foot in hot water. Okay, hot water. All right, hot water and soaking. Okay, chances of infection is higher. Okay, so this is not a good idea. Actually, this is not a good idea with bath salts. How much more with the bath salts? What's in the bath salts? Salts are sodium chloride, right? Sodium chloride attracts fluids. In other words, it will trigger more inflammation. It will trigger more swelling of that particular wound. Okay, so it's not good. That salts, though it's you know, I would say it's a solution for it's an antiseptic solution, but again, too much salts will acquire more fluids. In other words, it can trigger more swelling. All right. Patient reports increasing anxiety and feeling of hopelessness. Oh, there's a little bit of anxiety and hopelessness. Probably the patient has a history of depression, which is pretty much common here in the US. Let's take a look at the temperature. You said infection, right? So let's validate it using our other parameters like your vital signs. Okay. Temperature is 101 degree Fahrenheit, which is 38.3. Yes. Okay. 90, which is pretty much it's on the high side, which is not good. 13 is normal, which is good. Okay. In other words, the patient is not on respiratory distress. The blood pressure is okay. All right, unless it goes down to less than 90 or less than that, which is trending down and probably out of the baseline blood pressure of your patient. The pulse oximetry is 93% on room air, which is good. 93% is still good. The patient is on room air, so there's nothing to worry about the respiratory status of your patient. Okay, so these are the parameters that are already in your mind. Okay, you're already reading it. Okay, you just kind of like correlate it with your case scenario. All right, so infection, it could be like sepsis, it could be like septic shock. Well, this is not septic shock because the blood pressure is still good. All right, so I may be thinking about other condition. All right, so let's take a look at other parameters some more. Okay, so history and physical profile. So the medical history of your patient has a type 2 diabetes. I told you guys, don't look at it, don't get too excited on your question and answer, okay? On your bow tie question. Nothing yet, all right? Not yet. Type 2 diabetes, insulin dependent, all right? Patients who have type 2 diabetes are most of the time they are managed with the oral hypoglycemics. All right, the OHA, we call it OHA, like OHA, oral hypoglycemic agents. Like the first line is metformin, right? The first line is metformin. You can have like sulfonylureas, but it's the most hypoglycemic among them all. So be careful about prescribing that. And yeah, so there could be, this patient might not be managed well by the oral hypoglycemics. So chances are they're gonna get an insulin, especially your A1C or hemoglobin A1C is more than 7%. Okay, so this is our parameter here. Okay, this is knowledge. All right, this is A1C, the most important indicator of your good management. In your diabetes is basically your A1C. You always go from your A1C. Whenever your A1C is messed up, right? Especially if you're diabetic, chances are, okay, you're gonna bump up your insulin dose. Okay, chances are. Okay, but sometimes it could be a false positive one, especially if your patient has an ESRD because of a certain mechanism. Like I don't want to talk about it, carbamylation or those stuff. But anyway, so yeah, hyperlipidemia, that's another concomitant disorder. CAD, coronary artery disease. So he has a history of coronary artery disease. Let's take a look at the medications later on. Hypertension, ESRD. The patient is a dialysis patient who has a left AV fistula. Okay, his dialysis schedule is Monday, Wednesday, Friday. Okay, yeah. So I still have time, right? Okay, it's 30 minutes past. But anyway, I think we're having a good a discussion here. So I don't care about Mamilanes. Forgive me. I may talk, some more, beyond our minutes, beyond our time. But yeah, depression. Oh, there you go. I told you earlier. There's a little bit of hopelessness and anxiety as part of your assessment. So there's depression. Let's take a look if this patient is really taking some, depression medication, anti-anxiety medications. All right, it's pretty common here, like I said. So surgical history of appendectomy apart from that fistula, and then hernia repair, which is common here as well, and a BMI of 32, which is not a good one. The normal BMI will not have to exceed more than 25, right? More than 25 BMI is not good. Okay, more than 25 BMI is not good. How much more if it's 30? Okay, 30% or more BMI is not good. You're high risk to develop some of the metabolic syndrome disorders, for example, hyperlipidemia, like diabetes, like those stuff. Okay, or coronary artery disease. So it's not a good BMI. So in this case, the patient's BMI is 32, which is again which is abnormal. Okay, so the patient is pretty much morbidly obese. Okay, and the social history, the patient is a chronic smoker. I think it would not validate the fact that the patient is telling that he adheres to the medications well. All right. So, well, the patient is chronic smoker. So there's some kind of like a gray gray zone in there, like believing that the patient is really adhering to the medication regimen. You understand what I mean here? No history of substance abuse, which is actually okay because it may trigger more problems. Yeah, so substance abuse like taking alcohol, or taking, for example, like uh controlled medications. Okay, so allergies, the patient is allergic to penicillin. Lip swelling and tongue swelling, characterized by lip swelling and tongue swelling, had cephalosporin before and carbapenems in the past admissions with no reactions. So I would like you to have some knowledge about antibiotics as well. So the patient did not react to cephalosporins and carbapenems before. Okay, carbapenems is it's a high-end antibiotics, especially covering gram-negative microorganisms. It has a coverage also of your gram-positive. In other words, it's an empiric kind of antibiotics wherein it covers both gram-positive and gram-negative. Cephalosporins, it depends upon what kind of cephalosporins. All right. A cephalosporin can be good coverage with gram-positive and gram-negative, especially with your third and fourth generation. But when you say like first generation and second generation, it's good to your gram-positive. All right. And actually, your fifth generation is good for your gram-negative though, but a little coverage to your gram-positive. But anyway, so those are actually deep knowledge. They're not gonna ask you what specific antibiotics you're gonna prescribe to this patient, but I guess the basics. All right. For example, like if you're giving vancomycin on this patient, remember this is an ESRD patient. Vancomycin is a renal killer. In other words, it's a renal toxic, so you cannot give vancomycin on this patient. If you're gonna give vancomycin to this patient, you really have to consult the pharmacist. All right, if this patient can really tolerate vancomycin, considering the renal status of your patient. So the renal status can be considered. This is very complex. All right, this case is actually very complex. And so the reason why they updated the NCLEX is that primarily because patients nowadays are becoming complex. All right. On a single patient, you can see everything. Look at this diagnosis here. Look at the medical history. Everything is there on a single patient. Like way before, back in the days when I was a new nurse. Shout out to those batchmates if you're listening right now. Yeah. So if you remember when we take care of our patients before, we only take care of, let's say, hypertension, or let's just say CHF, and that's it. Not much of concomitant disorders, not much of comorbidities. But nowadays, on a single patient, name it, you have it. Well, in fact, when you take care of a patient in the regular floor, they are actually ICU-able patient. You know what I mean? Like these patients are actually toxic that are candidate for ICU. We cannot see that in the regular floors before. Okay, we can only see that in an ICU setting. All right, that means to say that the patients nowadays are really complex in terms of what they are experiencing, and coupled with it is the psychological problems of your patients. Depression and schizophrenia. There's a lot. Okay, so anyway, so we have to consider all the parameters in answering your questions. Okay, so let's take a look at the other parameters. At 1800, here's the problem. The patient is increasingly altered. All right, it's increasingly altered. You recheck the vital signs and it showed 101 degree Fahrenheit. Not much of it's not really progressing. It's still fever though. The heart rate is going up. Okay, from 90, I guess it's from 90 to 110. The respiration is also going up. So it's borderline. The normal is like 12 to 16, right? And then the blood pressure is 123 over 78. The blood pressure is also going up. But good thing is, the patient is not having a low blood pressure because you're considering some form of a shock. Okay. So the pulse oximetry is 95% on room air, which is good because we're still not supplementing the patient as much as possible. You don't supplement it with oxygen. Uh, yeah, because this patient is still doing good on room air. Okay. So 95% on the room air. So not in respiratory distress. What is your concern here is really okay. So the temperature, the heart rate, and not really the respiration. All right, but you have to monitor the blood pressure. Okay, so let's move on to the history and physical profile. Okay, home medications. If you click it again, all right, home medications is showing amlodipine because the patient is hypertensive. The patient is also taking aspirin. That's a gold standard if you have coronary artery disease, which is good. Atorvastatin because the patient is with hyperlipidemia, okay, or dyslipidemia. Metoprolol because the patient had a history of CAD, coronary artery disease, and who knows, it will develop some form of heart failure. Metoprolol is a gold standard in there. Insulin Glargine, or also known as your Lantus, that's the brand name. So because the patient is diabetic, and type 2 diabetes, however, probably the A1C is not controlled. That's why you have insulin with you guys, okay? And insulin Humalog, this is your Lispro. We call it Lispro. Sometimes we call it seafood insulin because, I mean, it's not coming from a seafood. It's not based from a seafood. The thing is, Lispro insulin is a seafood insulin because you need to see food, in other words, with meals, before you give that medication. It's a rapid acting medication, okay? So Lispro insulin, just like your aspart insulin and your glulysin, I guess, glulysin, these are, this insulin are rapid acting insulin. And so that's the most rapid acting insulin over your regular insulin. We have Lispro, glulysin, and your aspart. But anyway, most commonly we give Lispro, right, as a rapid acting insulin. So the patient is getting 4 units TID with meals. Like I said, with meals because this is a seafood insulin, all right? You have to see the food first, okay, before you give this medication. Well, guys, it can come out in your examination, all right? Whether you like it or not, whether you like endocrine system or not, it will come out in your examination, especially talking about insulin, all right? So you need to see food first before, giving the medication, all right, giving the insulin. And the patient is taking Zoloft, which is a sertraline. Yeah, sertraline Zoloft is an SSRI for depression. So it's an antidepressant. I told you earlier, the patient is having hopelessness and anxiety. Well, the patient is normally or routinely taking sertraline or your Zoloft. Okay, these are the medications. I guess I don't have any questions about these medications. These are good to go medications. Probably like a little revision. All right. And let's take a look at more parameters here. Okay, let's take a look at the labs. All right. WBC. The WBC is 12,000. Is this elevated or not? Yes, I'm going to encircle this one. Okay. The good thing about NGN is that, the reference ranges are already shown. Okay, so you will not have hard time in comparing, okay, what's in your mind? Okay, this is the normal value of my WBC or what? Well, you don't need to do that because it's already presented. Okay, so all you need to do is just to highlight it. All right, so you cannot do highlighting in the computer. You can make use of your an extra paper. Actually, it's a dry erase kind of writing material wherein you can put down notes. All right, so you just have to highlight this one, I guess. And hemoglobin is 12, which is normal. Hematocrit is 38%, which is normal. Platelets, I'm just gonna encircle those abnormal. 350, which is abnormal, probably reactive to infection. It's just a reaction, so nothing to worry about this one. And platelet is just simply reacting, so that's why it's elevated. A1C, there you go. A1C is 10%. So, you might revise your insulin management here. Okay, but I guess it looks like the insulin management 4 units and 35 units, there's supposed to be like a calculation. Of course, I'm not going to discuss about the calculation and how you give your insulin to your patients, but yeah. So I think it looks like it's appropriate for the patient. But looking at the A1C, it might need some revision, and the patient is admitted in the inpatient setting. So this patient might get an insulin sliding scale, right? Whenever the patient is admitted to the hospital, all right, what we usually do is do the sliding scale with insulin coverage, okay, in an acute care setting. When they go home, and then they can just resume their, their Lantus and their usual Lispro insulin, okay? So yeah, so random glucose is 181. Random glucose is abnormal as well, 181. But you know what? In managing your diabetes, you don't really need to see fully necessary. It's not really fully necessary to see that your random blood sugar is within normal range. Okay, the guidelines according to American Diabetes Association is just to see it near normal, near normal values of your random blood glucose. Okay, so 181 is as long as it will not exceed more than 200, because that's something else. All right, 181 is still acceptable, though it's not within normal range, but it's near normal, which is 70 to 110. Some books will tell you 80 to 120. So this is considerably managed or controlled. All right. So with the insulin that he's getting, the Lispro, which is 4 units, and the Lantus is like 35 units, if I'm going to calculate it, it's pretty much in the in the range. Okay. So the patient is getting the good amount of insulin. And of course, if you're giving insulin, you have to be very careful about it, because the most important adverse is, that hypoglycemia. All right. So whenever I talk here, guys, whenever I talk here, as much as possible, I will talk to you like everything that I will say gives relevance. All right. So if I may talk fast, you can actually put down notes. Oh, okay. The most important and the primary adverse effect of insulin is hypoglycemia. Okay, I will write down hypoglycemia. Well, uh, the principle says, according to American Diabetes Association, is it has to be not fully necessary, within normal range. It's okay to be like near normal range. Those are the things that I want you to take down. All right. So sir, the blood sugar is 181. I don't care about it. I care about it. Of course, it's elevated, but you know what? According to the guidelines, at least it doesn't go beyond like 200. All right. 181 is still acceptable, especially if the patient is chronically having diabetes. All right. The sodium is okay. I don't worry about this. I worry about A1C because it's 10%, so it needs more revision to your insulin sliding scale. But like I said, the patient is ESRD patient. If your patient is an ESRD patient, there should be something wrong with the hemoglobin. All right. We call it as your carbamylization of your hemoglobin, if I said it right. So there might be false positive results for your A1C, but I don't want you to dig in with that. Well, sodium is 136, like I said, is normal. Potassium is 5.0, which is normal. BUN or BUN is 45, which is expectedly high because the patient is a dialysis patient. All right. So it's expectedly high, including your creatinine. All right. So just to give you a little question, what is more specific? Is it your BUN or creatinine? Specific to like a kidney disorder. Is it your BUN? Oh, this patient is really having a kidney disorder. Is it your BUN or 2.1? It's a gimme kind of question. It's your creatinine. All right, creatinine over your BUN. Okay, so it's more specific in diagnosing kidney disorders. Creatinine. Okay, so your estimated GFR is 25. The normal is more than 90%. Of course, you're an ESRD patient. Expectedly, it has to go. It has to go down. All right, so it's expected. All right. And one principle also of your diabetes in terms of management, please, apart from preventing your hypoglycemia, apart from insulin management, is to limit complication. All right. So to limit complication, you can have many complications to your diabetes. You know that very well. All right. I guess I may need some more time to discuss comprehensively about diabetes and all this stuff. Let's go to our question, I guess. Let's go to our question. So come and join us in our IPOS Online Review and Mentoring Academy. I can expound more on my lectures there. I can do the pathophysiology, which is very, very important. All right, in in dealing with your diseases. That's your foundation. That's very foundational. All right, so that's basic. Wherein you need it in your NCLEX, especially in this kind of questioning, right? The case studies. You need the pathophysiology, right? Whether you like the pathophysiology or not, you really need it. That's your foundation. If you don't understand the pathophysiology, and everything will follow. You may not answer what's the, how to recognize cues, what's the most important cues, what are the things that you need to do, what are the interventions, what are the medications that are appropriate for this patient. Everything is useless if you don't understand the pathophysiology. All right. So yeah, so let's I think we're gonna answer this question. Oh, this is the physician's order. It's not done yet. Okay. So there's a lot of parameters. So pretty much this case study is kind of complicated in a sense because the patient has a lot of concomitant disorders. Okay. Hi, Sir Jay Franklin, watching from Philippines. Oh, Franklin is one of our firemen who is still in the journey of this NCLEX. I know you're gonna make it, Mr. Franklin. Hi, Ryan, one of our educators. Just a little shout out. Jessica, creatinine. Very good, Jessica. Okay, creatinine is the most important. I mean, most specific indicator. I mean, it's a gimme kind of question. Paul Terence is Team Repolyo. So do you have a Team Repolyo, right? Is that the 13th cycle? But anyway, so without yeah, so this is your physician's order. Monitor vital signs closely. Bolus of 250 ml, you kind of like conservative. You can probably like question the doctor about giving the bolus because the patient has an ESRD. He's a dialysis patient. 250 is kind of conservative, so I guess I'm okay with this one, unless if it's like 500 or 1 liter. So that's gonna congest your patient, right? So acetaminophen every 6 hours, PRN for fever. Obviously, the patient has fever, so you need to get some PRN medications there. Obtain pan cultures. When you say like pan cultures, this pertains to what? Your blood culture, everything, urine culture, and if you can get some wound culture, okay? Because the source of the infection pretty much is the of course high likely, of course, it's coming from a wound, but of course you also need to consider other stuff because again the patient has a lot of concomitant disorders. So wound cultures, I'm not gonna rely most of the wound culture because it could be, it could be contamination when you get the sample. All right. So the best wound culture that can be done to the patient is a deep wound culture, wherein a specialist can do it, especially during, for example, if they're gonna order like IND, incision and drainage, and then they're gonna get a sample from there. Yes, it's a reliable one because it's a deep culture. At the same time, it uh, absolutely it avoids some form of contamination because in a sterile environment doing your, it's done in a sterile environment doing your IND. Okay, so yeah, so you can, I mean, if you do your wound culture, most likely it's contamination, unless if it's done in a sterile environment, again, during your IND. All right, watching from Kenya, Miss Rose. Watching from Bahrain, Miss Jane. Leon is also from California. I think it's early in California right now. Okay, start imipinem. Imipinem is carbapenem. Okay, imipenem is one of the carbapenems. I told you, it's a high-end kind of antibiotics. In fact, it's the highest end on on the gram-negative side, but it also covers gram-positive. So I would like to ask you guys, what do you think is most likely or high likely the microorganism here? Okay, guys, what's this patient is suffering from diabetes and everything is there, all right, and having a diabetic foot. Okay, that's just right here, diabetic foot. Most likely, what kind of microorganism is this? So to see, if we are giving the right antibiotics on this patient. Okay, come on, guys, it's your turn. What do you think is the microorganism here? What do you think is the microorganism here? For us to say if your antibiotics is is appropriate for that. Okay, the patient is having some form of skin infection, right? Diabetic foot. Okay, foot infection, which is pretty common complication among diabetic patients. A chronic complication. Come on, I'm looking at your answers in the group chat. I mean, in the comment section. Come on, come on, come on, guys. What's your answer? What's the usual cause, or what's the usual causative agent on this particular infection? Come on. I think I'm not seeing your answers. I think you're kind of scared. I don't know. Or probably my Facebook is delayed. Gram positive. All right. So gram positive. Usually the gram positives are the streptococcal, the staphylococcal infection. Staphylococcus aureus. There you go. That's your Staphylococcus aureus. Staphylococcus aureus is a gram positive one. Okay. Most of the time, your diabetic foot is usually associated with Staphylococcus aureus. It's very abundant. Your Staphylococcus aureus can be methicillin resistant. Okay, your MRSA, in which you don't like it because it's a high virulent kind of microorganism. Okay, it's an antibiotic resistant kind of microorganism. The other one would be MSSA. The MSSA is methicillin. If you have methicillin resistant, you also have your methicillin sensitive Staphylococcus aureus. Your MSSA can be managed by basic antibiotics like oxacillin, like nafcillin, for instance. These are low-end antibiotics that covers Staphylococcus aureus as long as it's methicillin sensitive. But if you're talking about MRSA, okay, if you're talking about MRSA, it's a different story. You really need to get something like a medication that covers a high-end kind of antibiotics that covers your MRSA. The drug of choice for MRSA, I told you earlier, okay. By the way, according to studies, patients with diabetic foot will have anticipatedly you will anticipate 15 to 20% of them will have staphylococcus kind of microorganism. So that's a pretty big number. It's a pretty big fraction in terms of considering, okay, this is staphylococcus kind of microorganism. In other words, you go from there in terms of what kind of antibiotics you're giving. Now, the drug of choice for MRSA, is vancomycin. Okay? Take note. The drug of choice is vancomycin. However, considering the renal status of your patient, right? Considering the renal status of your patient wherein the GFR is way too low, like less than 25 or less than 35, you cannot give vancomycin. It's going to kill the kidney some more. Okay? So you choose other antibiotics that are not as much as, renal toxic, just like your vancomycin. You cannot give piperacillin on this patient that has a good coverage with your staph infections. All right, gram positive and gram negative. However, it's more of like the pseudomonas, and who knows, this is pseudomonas as well, right? But you cannot give it because the patient is allergic to penicillin. Piperacillin tazobactam is a penicillin-based kind of antibiotics, right? Piperacillin, right? Tazobactam, right? You cannot give that. So the only thing that I can see here, imipenem is a good one because it covers anaerobic and aerobic microorganism. It covers both gram positive and negative. All right. Imipenem is renal toxic if the patient you know, uh, has a GFR of less than 30. Okay, but you can adjust the dose. But if you compare it to other antibiotics, like for example, like vancomycin, well, vancomycin is super renal toxic. Well, you say like imipenem, less renal toxic as long as you adjust the dose on a low dose. For example, like this one is daily. We can actually give your imipenem 500 like every 6 hours. But considering your patient is having renal disease who is getting dialysis, I guess 500 milligram daily is just good enough for this patient, not to insult your renal system. Okay, they usually base it from the GFR of your patient. So if the GFR is less than 30, you can give 500 milligram of your imipenem on a daily dose, which is good. All right. And then if the patient improves after 40 to 72 hours, and then the patient can actually go home, all right, the patient improves, it means to say that vital signs, everything is okay, the WBC is okay, and I guess you're good. And then you can just switch it to a PO antibiotics, oral antibiotics. Okay, and you cannot give clindamycin anymore because the patient might develop resistance to clindamycin already. Okay, metronidazole, sir, yes, metronidazole is a good medication for anaerobic microorganism. All right. like C. diff, for example. Okay, piperaceline, like I said, if not metronidazole, I would metronidazole doesn't have a good coverage with your, with your MRSA, if there's MRSA. Okay, so yeah, so there are more or better antibiotics apart from your metronidazole. Like I said, metronidazole is very good for anaerobic microorganisms, especially if it's GI, colon infections, for instance, or gynecological infections, especially if it's anaerobic. Okay, so I guess we're talking about antibiotics, knowledge here. But yeah, let's proceed to your question. The nurse is reviewing the client's assessment. All right. The nurse is, let me erase this one. It's too crowded. It's too traffic. Okay. So the nurse is reviewing the client's assessments data to prepare the client's plan of care. Complete the diagram by dragging the choices below to specify what condition the client is most likely experiencing, 2 actions the nurse has to take to address that condition, and 2 parameters the nurse should monitor to assess the clients. I told you, these choices here might be all correct, but you just have to choose, the 2 most important nursing actions. The same way as with your parameters to monitor. It could all be correct, but you only choose, the most important. That's basically critical thinking. That's basically prioritization. All right? Prioritization kind of questions are really good because it will really test your clinical judgment. Whoever am I going to prioritize? Because most of them are like priority, but what is the most priority? What is the intermediate priority? And what is the low priority? You answer first the potential problem, huh? You answer first the potential problem, and then you go from there. If you were able to answer the potential problem, you just have to drag and drop it. See, it really looks like a bow tie, right? It really looks like a bow tie. So if you got the potential problem and then you know what are the actions to take, and you will also know what are the parameters to monitor. Okay? So potential problem. So let's go first with your potential problem. I guess I have a bigger picture here. There you go. You just have to drag and drop, to this particular box here in the bow tie. Okay, so what's your potential diagnosis here? That's my question, guys. How about meropenem? Meropenem is okay. Okay, meropenem is okay. That's a good one. Yeah, that's a good medication. But there is this imipenem, all right? Imipenem with cilastatin. Imipenem with cilastatin. The cilastatin part is actually a potentiative, not potentiative, but yeah, it will limit renal toxicity. So it's a mixture because there's no such thing as meropenem and cilastatin. The only thing is we have the imipenem and as well as your cilastatin. So again, cilastatin is an additive. It's an additive that prevents you from having renal toxicity, which is good. Okay, so I do not go with meropenem. All right, I go with imipenem because again, it covers anaerobic and aerobic. It covers gram positive and gram negative. Okay, so does it have a good coverage with your MRSA as well? Yes, it has a good coverage on MRSA. Remember, it's a high in antibiotics, which covers gram positive, gram negative. Okay, the good thing about it is that there's a mixture of cilastatin. Cilastatin is gonna prevent you from having renal toxicity, which is good. Okay, so there's so much to learn about these antibiotics, guys. I hope I can give you some. I think I already discussed antibiotic ladder before. Something to do with the discussion about antibiotics. So whatever we're gonna give to this patient, so whatever is the most appropriate for this patient. We really have to learn that because emerging microorganisms nowadays are becoming so potent. Okay, this is where we got our antibiotic resistance. Okay, this is where we got our antibiotic resistance. There's a lot of probably you can watch some like videos or documentaries related to emerging microorganisms that's related to antibiotic resistance. Very interesting. So you can really see that, okay, this is the silent type of pandemic. I'm telling you, this is a silent type of pandemic because we don't use our antibiotics very well. All right. So in other words, maluse or abnormal usage of, how do you say it? Like, yeah. So inappropriate use of antibiotics. Okay, that's why we develop antibiotic resistance. And there are actually many factors that will, that are predisposing to develop antibiotic resistance. But anyway, let's answer this question, guys. What's your potential problem? What's your potential diagnosis? Come on. Sears. Sears is what we call as your systemic inflammatory, all right, response syndrome, right? So it's a group of, it's a group of signs or parameters, okay, which is caused by a systemic inflammation response by your body. So it's just simply a response by your body, okay. And let's say Sears. Sears has, okay, let me discuss to you about sepsis continuum. In your sepsis continuum, we have 4 particular stages. Number 1 is your Sears. Okay, that's number 1. Continuum means what? It can develop from one to the other. Okay, so from Sears, from Sears to your what? To your sepsis. All right, to your sepsis. From sepsis, it can develop. It's not managed well. It can develop into what? To your septic shock. Okay, you know this very well if you're working in the hospital. All right, if you don't manage well your septic shock, or let's say if you don't manage the sepsis continuum in general, okay, it will develop into MODS. Okay, MODS is what we call as your multi-organ, multi-organ dysfunction syndrome. Okay, multi-organ dysfunction syndrome. So that's we don't want it. Okay, it's going to insult your multi-organ system. Liver failure, AST, ALT is very high, like even your brain, like even your heart. It causes elevated troponins, and ultimately your kidneys as well. It's gonna elevate your BO and creatinine. In other words, it affects all the organs. I mean, not all the organs, but it affects potentially other organs in your body. Okay, your Sears. Okay, in order for you to determine this is Sears, considering the parameters. For example, like the temperature. Okay, considering the temperature, considering the heart rate, considering also your what else? Your WBC, and considering also your respiratory rate. These are the 4 main parameters for you to say that this is SIRS, or systemic inflammatory response syndrome. For example, if your temperature is 100.4, more than 100.4, or less than 98 or 96.8, sorry. All right. So if it's more than 100.4 Fahrenheit or less than 96.8, in degrees Celsius, if it's more than 38, patient is having fever, or if the patient is having hypothermia, which is less than 36 or 36 or less. Okay. Heart rate, if your heart rate is 90 or above, okay, if your heart rate is 90 or above, and then, well, this patient has a SIRS. Okay. By the way, 2 out of 4 of these parameters, if you have that 2, and then you can say that this is SIRS. WBC, if it's 4,000 or less, okay, or more than 12,000. So is the patient more than 12,000? Looking at the WBC, yes, the patient has more than 12,000. So yes, so it's one of the parameters that we need to consider. What about the temperature, guys? The temperature is 100.4. I guess the patient is there, so we can 2 out of 4 already. All right. So what about your heart rate? 90. So 3 out of 4. So the patient's heart rate is already 110 actually. So yeah, so 3 out of 4 are patient. If you look at the parameters on our case study, the respiration is pretty much okay. If the respiration is more than 20 or more, and then you can say that this is also part of the Sears parameter. So let's just say the actual one is 3 out of 4. Okay, so you can say that this patient is having Sears. However, let's take a look at the sepsis. Sepsis, you did not identify, so you should have a positive identification of your microorganism. All right, by doing your cultures, right? After 24 hours, you can have your preliminary, blood cultures. Okay, but you know what? Yeah, so it's obvious that there is already, there's already a wound infection. But looking at the parameters, technically, is this SIRS or sepsis? Okay, is the patient's blood pressure went down already? No. If it goes down beyond 90, systolic blood pressure, So I can say that this patient is having septic shock already, right? But no, it's not. So it's just between sears and sepsis. But you know what? In sepsis, you did not identify yet, what kind of microorganism is that. So I guess I would stick with your sears. Okay, I would stick with your sears. No septic shock because the blood pressure is still okay. And of course, the multi organ dysfunction syndrome is not entertained here because the patient is most likely from sears to sepsis. Okay, so 3 out of 4. That's I would answer: is it sears, sepsis, septic shock, hyperglycemia, or ESRD? I don't worry about ESRD. It's a chronic condition, right? So you worry about the current condition of your patient, right? You worry about the current condition of your patient. So I'm going to eliminate ESRD. Hyperglycemia, yes. The patient has a hyperglycemia. However, it's controlled, right? It's controlled by the insulin. So I don't need to worry about that. So I'm going to eliminate septic shock because septic shock, the blood pressure is still okay. So I'm kind of like in between sears and sepsis. Okay, sears and sepsis. But I would say, between sears and sepsis, looking at the parameters, okay, looking at the parameters, I would go with your sears because you weren't able to identify what kind of microorganism that the patient is getting. All right, but well, high likely it's a MRSA though, or staph infection, but we'll never know. All right, it could be a different kind of microorganism. So I would eliminate sepsis. I would pick sears. So I'm gonna, drag and drop it here in the middle. Okay, so let's take a look at the. Okay, let me erase some portions here. Okay, so your diagnosis is sears. That's your potential diagnosis. That's your potential diagnosis. So if you're looking at the NGN, next generation NCLEX, it's like ruling out some diagnosis. It's like a medical kind of diagnosis wherein, you need to pick what kind of diagnosis my patient is experiencing. You're like a doctor, in other words. So you really have to keep up with, the what the doctors are doing. You know what I mean? Yes, that's the next generation NCLEX. If you just sit in a corner, not doing anything, not communicating to the doctor, you're not assessing your patient, you're not doing your job basically. All right, so you have to communicate it to the doctor. I think the you just have to communicate to the doctor, communicate effectively. What are your thoughts? What are your nursing assessment? What do you think about this patient? Communicate to the doctor, collaborate to the doctor because you're on the same team. All right, you're on the same team. That's basically next generation NCLEX. This is actually upbringing, the credibility of nurses in terms of working, effectively, safely, following the most standardized kind of care delivered to your patient. In other words, a very sound nurse, a very good nurse. Okay, so let's go to your nursing actions. So the problem here is serious. Okay, so are you going to administer basal insulin? Basal insulin is your glargine. Okay, so take note about those words, guys. Basal insulin, it's either basal insulin or your what do you call this? Your bolus insulin. Bolus insulin are what? Bolus insulin are those regular insulins, the rapid acting insulins, and the short acting insulins, like your regular insulins and your Lispro. Okay, so those are your bolus insulin, wherein you give bolus to your patient. Basal insulin is the glargine, the long-acting insulins. All right, these are the long-acting insulins that makes your patient's blood sugar on a steady state. Okay, on a steady state. So that's a basal insulin. All right, so you're giving it, for example, if you're giving it like in the morning, so it's gonna give it's gonna give insulin for the whole 24 hours. It's only given like once a day. So that's good for 24 hours. So that gives you a steady state of insulin that whenever you eat something, and then it's going to give you, okay, it's going to give you insulin. It's already given, by the way. So to control your blood sugar. So that's basal insulin, all right? Bolus insulins, on the other hand, are those insulins which are given during your, for example, like your sliding scale, all right? Either Lispro, that's your rapid acting insulin. And the other one would be the conventional regular insulin, the short acting insulins. Okay? So I'm not gonna pick this one. All right, because remember, the immediate problem here is the infection of your patient. All right, so uh, let's say between administer antibiotics, I guess I would administer antibiotics. Okay, I will pick this one. I'm gonna drag this one in here. You know what? According to many studies, you really have to start the antibiotics as soon as possible. Of course, before starting antibiotics, it's preferably, all right, it's preferably that you took already your cultures, okay, before starting your antibiotics. Okay, so yeah, so administering antibiotics, according to studies, whenever you miss antibiotics because you're kind of procrastinating, all right, if you miss antibiotics and then the patient is already in the setting of septic shock, it's never gonna be effective. All right. I mean, it will be still effective though, but it will have lesser potency. All right. Again, it's less effective when it's given if the patient is on the setting of septic shock. So as soon as possible, you start your antibiotics before it goes to septic shock. Did you understand what I mean? But make sure also, preferably, that you got your cultures before you start your antibiotics. Okay. So, obtain cultures, yes. Okay, obtain cultures. I'm gonna put this one here. In fact, obtain cultures is before you're starting antibiotics. Okay, so I'm going to eliminate your fluid bolus because it's not really necessary at this time to give bolus because the patient is ESRD patient. At the same time, the patient is still not experiencing septic shock. So bolus is not really the priority here unless if there's septic shock, and then I can give bolus, but you have to be very conservative on it because again the patient is having renal disease. I hope you're still learning, with my rationalization here. Okay, so let's go to your. So the answer would be like Sears, and your nursing actions to be taken are administering antibiotics, and before that you obtain your cultures, basing on the orders given by the doctor. Okay, let's move on to your parameters to monitor. All right, the parameters to monitor. So are you going to monitor the blood glucose? Yes, you're going to monitor the blood glucose because it gives impact to your infection as well. All right. Your serum lactate? Yes, serum lactate is a parameter in order for you to detect, anticipate, who knows. It can go into severe sepsis and then septic shock. So it's a good parameter for your sepsis. Okay. So I'm gonna check this one. But let's see what can we eliminate here. The dialysis. Okay, so dialysis, it can wait. All right, it can wait. So I'm not gonna pick that. Okay, the immediate problem of our patient now is the infection. Okay, so I was left with blood sugar monitoring, serum lactate, and vital signs every 15 minutes. Okay, you already took your blood sugar, right? What was it? Like 181. Okay, so you think it can wait? It's not, it's pretty much controlled, and you have insulin as well. So I don't think this blood sugar can it wait? Yes or no? I think it can wait. So between blood sugar and vital signs, I would rather do the vital signs first before the blood glucose, because in the first place, I don't want this patient to go into sepsis. I don't want this patient to go into septic shock. I have to monitor the vital signs. And remember, the patient is already having altered mental status, increasingly agitated. So that's also a sign of impending what? Impending sepsis. Okay? So I would pick your vital signs right here. I'm going to put it here, vital signs, and as well as your serum lactate. Okay? As well as your serum lactate, because that's a good parameter. That's a very good parameter in looking after, is this septic shock? Is this sepsis or what? Severe sepsis. Whenever you have sepsis, it's gonna go up. Okay, somebody's calling me here. Anyway, so yeah, so the answers would be Sears. I hope you got the right answer. Okay, the answer would be Sears, technically basing on the sepsis continuum, wherein you have 3 out of 4. Okay, and then you haven't identified the microorganisms yet. Technically, I don't want to pick like sepsis, but you have to monitor for progression of sepsis. I would only pick sepsis. Okay, so let me erase. So to review, what are the answers? Okay, so erase, erase, erase. We're almost done, guys. We're almost done. Forgive me. I extended again. Okay, I don't want to limit, talking, especially if it has context in your NCLEX. All right, so let me just give you the answers just to review. Okay, I will pick what? Sears. All right, that's our answer, Sears. And nursing actions, I would pick what was it again? Cultures and as well as your antibiotics. Okay, what about the parameters to monitor? I would pick your serum lactates. Okay, lactate, serum lactate. It's a good indicator of your sepsis, but again, we'll never know the patient is already having sepsis. If it's elevated, okay, this is something is going on here, especially if the patient is already having some form of mental status changes, increasingly agitated. All right, and the other one would be vital signs monitoring because who knows, the blood pressure will go down. In fact, the vital signs are actually trending up. For example, the heart rate and as well as the temperature. And later on, the patient will have respiratory distress and blood pressure goes down. You know, looking after your septic shock. And we don't want it because uh, the progression is very, very fast, especially if the patient has a lot of concomitant disorders. Okay, so these are the answers to your bow tie. So we came up with an answer very quick, actually, but we had spent a lot of time in recognizing cues and stuff, right? Clicking all the parameters that will give us a baseline or basis for us to answer it well. Okay, so this is a point system, guys. It's a point system, but I don't want you to be confident. Oh, okay, this is a point system. I would probably get 1 or 2 points. No, you have to perfect it. You have to do well as much as possible. You were able to answer this, everything. Okay, so I don't want you to say, okay, it's a point system anyway, so I'm just gonna get 1 or 2 points. No, I want you to perfect the bow tie questions. I want you to perfect everything as much as you can. Right? If it's a point system, you have to build up points because that's gonna impact your total scores. Well, our goal is to stop by 85 items. All right, so that for us to say that the computer is 95 to 97% confident, okay, that this guy or this candidate is really good, and I will pass you. All right, so that's our goal, 85 items. But for some reason, of course, if the computer is not 95 to 97 confident that they're gonna pass you, it can go beyond like 85 items. It can go beyond up to 150 items. So it's going to be, this is where your preparation sets in, because answering 150 questions is a lot. Okay, and answering 150 questions is like make or break. Okay, whenever you get the 150th item correct, and then you pass. Whenever you get it wrong, and then unfortunately you will fail. All right, so yeah, so as much as possible, 85 items to make sure that the computer will be 95 to 97% confident. Okay, I guess yeah, that's our discussion for today, and I hope we'll have some more discussions in the future. To those who are still contemplating, I told you already, yeah, so procrastination is the master of thieves. It will just simply make hard things harder and hardest. It will make things easy things harder. You know what I mean? But you know what? Just it's just a matter of 6 months. It's just a matter of 6 months sacrifice, and then at the end of the day, we look up with our motivation, of course, and then you will see after 6 months you got the passing result, and then yeah, you're good. It's gonna be permanent, okay, because it's God given. I told you already. All right. Yeah. So see you guys in the future. Hopefully next month I'll give you the another lecture, another case study, or another concept about NCLEX. Thank you for coming today, and God bless everyone, and happy Easter Monday. Okay, thank you.